Bismillahirrahmanirrahim. My first case is a 48-year-old female who presented with anginal chest pain. And this was the ECG, which is almost unremarkable. But the consultant still felt that the patient is having typical angina symptoms and should undergo conventional angiography. Personally, I might not have recommended this, but the consultant opted for a conventional angiogram. And the echocardiogram revealed before conventional angiography that patient had moderate aortic stenosis with mild LVH. This is the conventional angiography of the patient done through radial approach. Now, some very basic questions. Where is the catheter in this case? Is it where it is supposed to be? Normally, when you do it from the radial road, you expect it to go to the ascending aorta, but it is somewhere else. Where do you think is it? Where is it? It is in the descending thoracic aorta. So how did it reach there? Normally, ascending aorta is in line with the brachiocephalic trunk, and but this catheter has gone to the descending thoracic aorta. So how did it reach there? Sorry? Oh, wonderful. So, but why is not contrast going down the descending thoracic aorta? Sorry? Diverticulum. Let's see. Anyway, the procedure was abandoned because the catheter failed to advance and a cardiac CT was performed. And what we found was that there was anomalous right subclavian artery, as pointed out by Dr. Sharjeel. And in case of anomalous subclavian, that is the most distal vessel arising from the arch. So that's why the catheter directly went to the descending thoracic aorta. And moreover, during this process, the operator dissected the vessel, and there is a dissection flap in the यार इसका pointer काम करता है, pointer इसका काम, वो किधर है? ये देखिए dissection flap इसमें ना, तो इस व्यू में भी आप देखिएगा कि ये डिसेक्शन है सारी उसकी लेफ्ट सबक्लेवियन आर्टरी की, और ये इसमें सेक्शनल इमेज में आपको लेदर से उसका ल्यूमन नजर आ रहा है. Coronaries were anyway normal, and there was bicuspid aortic valve. So this was one of the complications of conventional angiography, which could have been avoided had the operator opted for a non-invasive testing before conventional angiography. However, this complication happened because of the direct effort for angiography. The final diagnosis is bicuspid aortic valve with moderate aortic stenosis, normal coronary arteries, anomalous right coronary artery, right subclavian artery, and there is type B dissection. And this is a very rare condition, and usually patients are asymptomatic. Sometimes this anomalous subclavian can become aneurysmal, and you can see a shadow in the chest X-ray just beside the trachea. And in this era of interventional cardiology, when a lot of people are doing coronary interventions through radial route, they must be aware of this anomaly, because this may coexist, and then that may lead their catheter away from where it is intended to be. The second case is a 20-year-old female who underwent surgical repair for ASD. But post-operatively, she complained of, immediately post-operatively, she complained of shortness of breath, which was not there pre-operatively. And there was desaturation. She was not able to maintain the oxygen saturation. So, what comes to your mind? Why should she become deoxygenated or short of breath when the anomaly which was there has been repaired? So what are different possibilities? Why should she become cyanotic or short of breath or hypoxic after ASD closure? Any guess? Like one of these possibilities, like one possibility is that she might have been a case of Eisenmenger, but that is not the case because the pulmonary pressures were low preoperatively. Second possibility is that there may be some residual ASD with prominent eustachian valve which directs the blood from IVC to the left atrium rather than right atrium. Or sometimes there are anomalous venous drainage, systemic venous drainage. So to confirm what is wrong, a saline study was done, and this is study after injection from upper limb. You see that contrast is coming to the right atrium, to the right ventricle, but there is little bit of contrast also goes to the left side. Oh, but there is little bit of it goes. But when the procedure was repeated from the lower limb, you see that the saline is going on both sides. At the same time, it is going to the LV and RV at the same time. So, what do you conclude from this? Possibly anomalous drainage of IVC. But to confirm that, a cardiac CT was performed, and that confirmed the diagnosis that this IVC is directly going to the LA, and it is giving deoxygenated blood to LA and to the systemic circulation. Yes, it was missed preoperatively, okay. Again, the CT images. I had a similar case a couple of years back when a child underwent total correction surgery for trough. And after that, they were not able to take him off the ventilator because of desaturation. They requested for a cardiac CT study. The trough was adequately corrected, pulmonary vessels were adequate, but still the boy was cyanotic. And the additional finding which we got was that the SVC, instead of going to the RA, is going directly to LA. Again, an anomaly of the venous system. Yeah, no, with the oxygen and so they also confirmed it with the conventional cath. You see that the pulmonary arteries are okay, RVT has been adequately repaired, but this injection in SVC leads to direct filling of the LA and LV. So they opened it again and did the surgery. So these are anomalies of SVC and IVC. These are rare, but one must be aware that in preoperative assessment you must look for these things. Otherwise, if you miss these things, then that will result in catastrophic. Third case is a 32-year-old girl who complained of shortness of breath and palpitations. The ECG revealed, the echocardiogram revealed an ASD and a mass in the RV. And T was advised, that also showed the same thing. The operator thought that it could be a lipoma on the right side of the right in the right ventricle. These are the echo images showing the mass in the RVOT producing significant obstruction. A cardiac CT was performed that again showed a mass in the RVOT and a secondary AST. A surgery was performed, and this is a surgery, and this was a histology of the case. You may remember the slides from your preclinical classes. What does this tissue look like? Sorry? This was thyroid tissue. Adult thyroid tissue in the heart. Okay? And so this is very rare condition, and only 20 cases has been reported so far, and mostly in the RV. And it is usually attached to the interventricular septum, and it has a broad base. The difference is from the myxoma is that it has got a broad base. Otherwise, it enhances just like myxoma. Another case, 44-year-old male, known case of tight aortic stenosis, and underwent cardiac CT before valve replacement. Coronaries were normal. Valve was bicuspid and highly calcified. But interestingly, on CT we just discovered this thing. A big mass attached to interatrial septum. And this was missed in previous echocardiogram. Why? Because when we find one pathology, we just concentrate on that pathology. We are too much involved in that pathology, and we are likely to miss the other things. So our echo should be very, very comprehensive, not missing anything. So final diagnosis was tight aortic stenosis and LA myxoma. These were two coincidental things which occurred together. Okay. So I think that's all. Thank you.